Our guest speaker today is Dr. Max Wintermark, who is an associate professor of radiology, neuroradiology, neurosurgery, and biomedical engineering, and chief of neuroradiology at University of Virginia School of Medicine. And also with us is Dr. Megan Strother, who is an associate professor of radiology and radiological sciences and neurological surgery at Vanderbilt University Medical Center. In the question and answer portion of this webinar, immediately following the presentation of Dr. Wintermark and Dr. Strother, we will be joined by Mark Oshevsky, product manager, and Scott Pullman, director of CT Clinical Science, both from Philips Healthcare. With that, I would like to take this time to thank our corporate sponsor, Philips Healthcare, for making today's webinar possible. Now, after the presentation, we will begin a live panel discussion. At that time, please feel free to submit questions for the panel's consideration at any time during the presentation. You can use the question option in your GoToWebinar dashboard. Please note your question window may be hidden behind the presentation window. So if this is the case on your monitor, please just move or minimize the presentation window to access the dashboard. So without further ado, let me introduce Dr. Wintermark and Dr. Strother. Welcome, doctors.
Thank you.
Thank you.
Thanks for inviting me. There's much debate about imaging stroke. Dr. Wintermark and I could and may argue about the pros and cons of CT over MR, the reliability of perfusion software, or the parameters which should best guide treatment. Ongoing and future trials are needed to answer these important questions. However, I hope the radiologists listening to this webinar won't wait to start perfusion until all of these questions are clear. For me, CT perfusion is like being handed a treasure map with an X marking the spot. I use the perfusion studies to first evaluate in stroke. I start with the perfusion studies, then look at the CTA studies to find the occluded vessel. The perfusion studies save time in my assessment of strokes. One of the challenges of imaging stroke is outcomes can appear arbitrary. My first case is an 84-year-old female who developed sudden onset of right upper extremity weakness and an inability to speak. Her daughter recognized the urgency of the situation, and the patient was life-flighted into Vanderbilt for emergency stroke treatment. Her head CT was performed less than 2 hours after stroke onset. You can see a dense left MCA, which corresponds to thrombus. At this early stage of infarct, she had not developed parenchymal changes or hemorrhage. Her angiogram was performed 7 hours following the symptom onset. The left MCA is occluded. Following intraarterial thrombolysis, the vessel recanalized. Unfortunately for this patient, recanalization did not improve outcome. She developed a hemorrhagic infarct and died. That's the lesson we've learned from angiograms performed during stroke treatment over the past decades. Opening the vessel is technically satisfying, but it does not necessarily correlate with helping patients. We must move beyond plumbing analogies to parenchymal parameters. In this study, authors compared infarct volume, shown here, with both recanalization and reperfusion. And they found that reperfusion was a more accurate predictor of follow-up infarct volume than recanalization, shown here. Our challenge is to better understand which patients we can help by understanding the tissue parameters that predict outcomes. Our current treatment paradigms are based on stroke trials conducted over the past 2 decades. This figure summarizes the major intravenous TPA trials performed prior to 2004. On this figure, an odds ratio of 1 corresponds to no benefit over placebo. The 3-hour IV TPA treatment window is drawn from this data, which gives an odds ratio of approximately 1.7. Most of the benefit to patients from this data came from the NINDS trial, where half the patients were treated in less than 90 minutes. At 6 hours, outcomes for IV TPA pass into the potential to harm range here, leaving us with a frustratingly narrow window in which to intervene. Based on the NINDS trial, IV TPA is approved for 3 hours. The more recent ECAS-3 IV TPA trial shows benefit for patients to 4.5 hours. If you take home one message from this talk, I hope it will be to do everything you can to promote speedy treatment for your patients. In the ECAS-3 trial, for example, patients who received treatment between 3 and 4.5 hours had 50% less benefit than patients receiving treatment in the first 3 hours of their symptoms. After 4.5 hours, available stroke treatment is intra-arterial, out to 8 hours with mechanical thrombectomy. Currently, attempts to stratify patients to intravenous treatment beyond the 3 to 4.5 hour window using mismatch criteria, which compare the infarct volume and the volume of ischemic tissue, have not been significant. Results from the 4 mismatch-based trials which have been published are plotted here. The line bisecting the graph here is no benefit over placebo. The size of the squares corresponds to the number of patients in the study. When the Diaz-1 trial came out, shown here, mismatch-based treatment algorithm appeared to improve outcome, extending the treatment window to 9 hours. However, the Diaz-2 trial here, which was much larger, did not repeat these promising results. With our narrow window for treatment, we're missing the vast majority of patients. We have no treatment algorithm, for example, for patients who wake up with their symptoms, which is up to 1/4 of patients with stroke. The financial benefit to society if we could move that treatment window just 3 hours is estimated at $60 million. Here's the treatment algorithm we use at Vanderbilt. For patients presenting less than 4.5 hours from their stroke, we start with a non-contrast head CT. At the time they get the non-contrast head CT, they can get the CTA and the CT perfusion study. But the non-contrast head CT is the most important because that's the part that is going to direct further treatment. If there is no hemorrhage and less than 1/3 of the MCA territory is involved, then the patient can receive IV TPA. If there's hemorrhage or there's greater than 1/3 of the MCA territory involved, then there's no treatment. Patients who receive IV TPA or present within the 4.5 to 8 hour treatment window should certainly get CTA and CT perfusion studies to guide therapy. For these patients, if there's no thrombus identified, then they will not go on to intra-arterial treatment, but this CTA and CT perfusion data is essential for guiding the intra-arterial treatment. For patients over 8 hours, we prefer MR to quantify the diffusion as a gold standard for infarct, since there's no treatment for anterior circulation strokes after 8 hours. Dr. Wintermark, can you share your treatment algorithm with us?
Sure, Megan. So in a lot of ways, our philosophy is at the University of Virginia is very similar to the one that you have at Vanderbilt. A couple of very slight differences. We tend to use CT as our first line of imaging in all patients. In a similar way to you guys, we get just a non-contrast head CT in the patient admitted in the first 4.5 hours because, as you mentioned already in your talk, we want to get those patients to TP as quickly as possible, so we don't want imaging in any way to delay treatment. Then in the 4.5 to 8 hour time window, we do exactly the same thing as you guys are doing. We obtain CTA and CT perfusion in addition to the non-contrasted CT, again with the idea that this will help selecting the patient who will be the best candidate to respond to some kind of intra-arterial therapy. And then for all other patients, we usually just get a non-contrast head CT first, sometimes with a CTA, and a certain number of those patients are subsequently going to get MRI. And the idea behind these strategies, again, that at our institution, CT is easier to obtain in the acute stage to make a very initial treatment decision or a very initial management decision, and we keep MRI for the second stage to better characterize the type of stroke that the patient had or to try to understand what was the mechanism of the stroke so that our colleagues, the neurologists, can subsequently decide the optimal therapy to prevent the stroke from recurring.
Thank you, Max. That's helpful. I'd like to move on now to some more practical applications for performing CT perfusion well. I don't know. I'm not sure I have the mouse, though. Okay, here we go. This 22-year-old male developed sudden left-sided weakness at 10:45 in the morning. An hour and a half later, he had his head CT, CTA, and CT perfusion. The CT was read as no acute findings. I'll let you be the judge. Think retrospectively, you may appreciate some early obscuration of the gray-white margins in the right cerebral hemisphere. This kind of subtle parenchymal change is not a contraindication for IV TPA. Certainly, the CT perfusion study makes the change more obvious. On this threshold image, the red here represents infarct, the green suspected areas of ischemia or penumbra. The green is tissue at risk, which may proceed to infarct, but is not already dead. With perfusion imaging, tissue parameters include cerebral blood flow, shown here, which is decreased, cerebral blood volume, also decreased, and an increase in mean transit time on this patient. As the perfusion pressure falls, the capillary bed initially dilates. That will increase both the mean transit time and the CBV, protecting the CBF initially. However, as perfusion pressure continues to decline, the brain's mechanism for protection fails. Dr. Wintermark has led our efforts as radiologists to understand the significance of the tissue parameters we can measure. In this series, which was the largest published at the time, he defined the infarct core to be best represented as CBV less than 2 milliliters per 100 grams, and the penumbra to be best represented by mean transit time greater than 145%. This is relative mean transit time. You're always going to compare the patient's abnormal side with the patient's normal size. To date, there's no consensus or high-level evidence on the best technique and threshold to use when measuring penumbra. The threshold image shown here best demonstrates both parameters, the CBV less than 2, the mean transit time greater than 145% compared to this contralateral side. One obstacle which has been frustrating is the lack of standardization of post-processing software across vendors. In this study, identical patient data sets were post-processed using the algorithms from different vendors. You can see the variability in cerebral blood flow. The same applies to calculations of mean transit times. These methodologies need to be tested and standardized. Fortunately, CBV values are consistent, so I think calculations of infarct volume using CBV are robust, and studies reporting CBV can be compared across vendors. On CTA, our patient had a T-shaped ICA terminus thrombus on the right. These ICA occlusions have high mortality rates. They are better treated with intra-arterial thrombolysis than IV TPA. In one study, only 4% of patients with ICA terminus occlusion recanalized with IV TPA compared to 40% recanalization with endovascular treatment. Our patient received IV TPA in the emergency department, then went immediately to angio. The ICA occlusion opened with mechanical thrombectomy followed by intra-arterial TPA. Notice the time of the angiogram, 2 hours after stroke onset. The follow-up MR and CT showed the anterior frontal lobe progressed to infarct, but the more posterior portion of the MCA territory, which we suspected to be ischemic, did not. Clinically, the patient did great, returning to law school with little, if any, deficit. I'll finish with a few technical notes. I performed CTP prior to the CTA. The contrast from the CT perfusion study does not degrade the CTA information. I don't find the venous opacification on the CTA from the contrast that we gave in the perfusion study to be problematic. Some people have eloquently used the CTA information to better time their CT perfusion studies to reduce unnecessary radiation. Either study can be performed first. If our CT perfusion study is degraded by motion, then we repeat it after the CTA, and that's fine too. This is the coverage I get using a 64 detector scanner. I'd say in this patient, as is often the case, this initial slice is too low. Ideally, the first slice would be here, so that more of the high MCA territory is covered. This is all of the coverage we're getting of the anterior circulation. The biggest challenge I have is the brain we're not covering. It's impossible to correctly predict mismatch volume when much of the territory is outside the field. I prefer CT perfusion for anterior circulation strokes and MR for posterior circulation strokes, as we've said. As you can see, the alignment here would need to be corrected if you're going to include the posterior fossa, and communicating this information to the technologist at the time of scanning has proven difficult. To overcome challenges imposed by the lack of total brain coverage with CT perfusion, vendors have offered a toggle table or shuttle mode. In this mode, the scan is acquired as the table and patient move between two locations. There are drawbacks. First, the gantry rotation slows down up to 3 seconds, which we know makes the CT perfusion values less quantifiable. Also, there is a theoretical concern that patient motion would blur the arterial input function. Motion is your enemy, so tape your patient's head down and repeat the study if the images are severely degraded. Your data will not be reliable if your images look like this. Here's a perfect first slice. Here are the source images for the patient's CT perfusion study. Hopefully. This patient has an occluded right MCA. The source images are post-processed by and identify the arterial input function as shown here. I typically use the anterior cerebral artery, but the normal MCA can be used. Venous outflow is usually from a large vein, such as the superior sagittal sinus or the sinus confluence. Vendors have automated this step with recent upgrades, which is particularly helpful when technologists are post-processing the source data rather than radiologists. Once you've selected your arterial and venous input functions, the time attenuation curve will be generated. Note that the transit time in this is relatively quick in this patient who's a young female. The venous curve here should be later and larger than the arterial curve here. I now routinely scan to 70 seconds to allow for patients such as this 77-year-old patient with atrial fibrillation. You don't want to exclude a portion of your time attenuation curve as was done here, or your perfusion values will be artificially low. In my next case, I have a patient with chronic left ICA occlusion here who developed a critical stenosis with a string sign here of her right ICA. I'll show you the source images from her CT perfusion study. Notice the delay in the transit time of her right MCA. So it's a little jerky, but hopefully you can see that the right MCA is delayed. It still has contrast in it even after the left MCA has cleared. This is confirmed from the mean transit time map, which is generated here. So the entire mean transit time for the entire middle cerebral artery on the right is delayed. You can draw a region of interest in any of the areas that are covered by your perfusion images. It's helpful when the software automates a mirror image of any RI you draw. And just as a technical point, do subtract your vessels if that's part of your perfusion software. We are not interested in endovascular blood volume, only parenchymal blood flow. So before you get the quantitative vessels numbers, you need to subtract the vessels. I've included normal perfusion parameters to remind myself to tell you the only reliable comparison is a contralateral mirror image, as we've discussed. Otherwise, you'll be averaging perfusion values for gray and white matter, which, as you can see here, differs significantly. In our patient, the right ICA opened with angioplasty here. And on follow-up, her infarct volume closely matched the expected tissue parameters with infarct here in the red, CBV less than 2. Much of this area of ischemia was protected. In my final case, I wanted to review ischemia. This patient has a left M2 occlusion. On the CT perfusion study, the left MCA is delayed here. The CBV is increased, so this patient is at this point of the falling perfusion pressure, and the CBF is maintained. This is the parameter of ischemia. Thank you for your time. We're very fortunate to have Dr. Wintermark, who is a worldwide expert in perfusion imaging, to speak to us now on perfusion CT. Thank you.
Thanks, Megan. You're too nice. So what I would like to do, so Dr. Strother did an excellent presentation on how to use perfusion CT and also on a number of technical points that you have to pay attention when you are processing your perfusion CT data set. What I would like to do during the time that has been important to me is to cover a few areas that she touched on, but I would like to go a little bit deeper. And the first area that I would like to discuss further is this variability of the results observed amongst the different softwares that are available on the market when you process. And basically it comes down to the fact that when you use the exact same data set, but you use different platforms to process those data sets, you may get results that are quite different. And I think that here the key element that I would like all the audience to remember is that there is not just one type of CT perfusion techniques, there are multiple types. And I think it's very important when you are dealing with your own perfusion CT data sets to know exactly what type of perfusion CT technique you are using and to be familiar also with the software that you are using to process your data, because that way you are going to understand your results and you are going to interpret them properly. It will also help you when you read the literature to know if you can just use the results that are reported in the different scientific articles and use them for your data sets, or if you have to be careful because the authors of that particular papers use a different techniques or different software from the one you are using, and in which case their overall results are probably still valid, but probably you need to translate a little bit the values that they have reported in their paper so that you can use them in your clinical practice. So to start from the beginning, I would like to first say that there are overall two big different types of perfusion CT techniques that you can use. The first one is called whole brain perfusion CT, and the second one is called dynamic perfusion CT. So for the first technique, and again, you have to be a little bit careful because there's been some evolution over time, so I'm going to try to not contribute to the confusion, but rather to try to clarify it a little bit. So when typically whole brain perfusion CT was developed, what people meant by this term was really to obtain first a non-contrast head CT, and then to obtain a CT angiogram while you are injecting a relatively long bolus of contrast. And as a result, because the bolus is long, you have a period of time where you have a plateau of concentration of iodinated contrast in your blood. And typically the CTA acquisition was performed during this plateau with a constant concentration of iodine. And then when you get those two data sets, the non-contrast head CT and this particular type of CTA, then you can subtract the non-contrast CT values from the corresponding voxels on the CTA study, and the difference, the result of the subtraction basically gives you the information about the whole brain perfusion CT. And the thing that is important to remember in that particular setting, so it's again illustrated on that slide. So you have a non-contrast head CT here in the left column. You have the corresponding CTA images at exactly the same level that were obtained during these long bolus with a constant concentration of iodinated contrast. And then you have here the subtraction images that you obtain by subtracting the non-contrast head CT from the CTA. And these images are the whole brain perfusion CT images. One thing that you have to remember about this technique is that it has a big advantage. It allows you to cover the whole brain, and that's of course an advantage because, as Dr. Strother mentioned earlier, you don't know exactly where the ischemia is going to happen, and by covering only a single slab of tissue, you run the risk that the ischemia may actually happen outside this slab, and you may miss the infarct of the patient, or you may not be able to correctly evaluate its extent or the ratio between infarct and penumbra. The drawbacks of this whole brain perfusion CT technique, as I described it, is that you can only assess the cerebral blood volume. So it's good, it gives you some information about the infarct, but you don't get the information about the mean transit time and the cerebral blood flow that you need in order to assess the ischemic penumbra. And again, that's something that Dr. Strother discussed. The infarct score gives you already a certain piece of information, but at the same time, the target of your treatment is the ischemic penumbra, so it would be nice to be able to also access that piece of information. The other large group of perfusion CT technique is called dynamic perfusion CT technique, and in that particular setting, things are different. In that particular setting, you are basically going to use your CT scanner as a monitor while you inject a relatively short bolus of contrast, typically 40, 50 cc's, and you are going to leave your CT scanner gantry in exactly the same location, and you are going to monitor over time with successive slitty slices at the same location how the contrast, the iodinated contrast, is washing in the brain and then washing out the brain. And you are going to be able to reconstruct those time concentration, those time density curves in each pixel of the brain, and then you are going to use a perfusion CT software to extract some perfusion information from those time attenuation curves. So a very different technique, a very different approach. You are still usually going to use to obtain a non-contrast CT prior to the perfusion CT, and you're also going to still obtain a CT angiogram either before or after the CT perfusion, but the CT perfusion data is going to be used by itself to calculate those perfusion maps. The advantage of that technique is that you are going to be able to assess not only the CBV, but also the mean transit time and the cerebral blood flow. And as I'm going to explain in a moment, that's going to help you characterize not only the infarct core, but also the ischemic penumbra, which again is the target of your treatment. One drawback of this technique, again, because the CT gantry is fixed and set in one specific location, you are going to potentially have a limitation in terms of spatial coverage. And that's where the type of scanner that you are using is going to play a role. If you have a 2 or 4 slice CT scanner, you are usually going to be limited to approximately 2 centimeters of coverage. If you have a 64 slice CT scanner, you are going to go up to 4 centimeters of coverage, as Dr. Strother described. Now you have some other approaches like the toggling table or the shuttle technique that allow you to double your coverage, so you can potentially go up to 8 centimeters. You can also use 2 consecutive bolus of contrast. You're also going to reach 8 centimeters, which is not very far from being a whole brain coverage. And finally, more recently, with the 128 and the 256 and the 320 slice CT scanner, you can obtain whole brain coverage. And that's why I wanted to draw your attention. I discussed at first this big group of perfusion CT technique called whole brain CT perfusion. And that's something that you don't want to confuse with dynamic perfusion CT, whatever the coverage for this dynamic perfusion CT is limited to a couple of centimeters or is very close to whole brain coverage. Because again, the approach and the type of information that you can extract is very different. So that was kind of my first message. Know if the type of CT perfusion that you are performing is just basically subtracting a non-contrast CT from a CTA, or if you obtain this dynamic sequential acquisition of sequential CT images during the wash-in and the wash-out of the contrast material. So that was the first thing that you need to determine about your CT perfusion technique. The second thing that you need to determine is what type of mathematical algorithm your software is using. And again, to be on the little simplistic side, there are 2 big groups. So now we are talking only about dynamic perfusion CT. We have exactly the same data set, the same raw data, but you can plug this data set in different types of software and you're going to get a different type of analysis. And again, you have 2 big groups of analysis. The first one is called the maximal slope model. And the idea of the maximal slope model was derived from microspheres, which was one of the first techniques used to characterize cerebral perfusion. And basically, when you the gist of that particular approach is it's a relatively simple approach. It allows for a very fast calculation. So from that perspective, it's an advantage. But the limitation is that it gives you only qualitative data. And I'm going to show you this example now on the right lower corner of the screen. So you have a patient who was imaged with stable xenon, which is considered to be one of the references for cerebral perfusion. So that's kind of your truth. And on the right of the stable xenon image, you have a CT perfusion dataset processed using a software using the maximal slope model. And if you look and you compare the truth, the gold standard image on the left and the perfusion CT image on the right, you can see that the values, the absolute values of brain perfusion are underestimated. So you cannot necessarily rely on those absolute values. Dr. Strother showed earlier those different values in the gray and the white matter. Typically, if you are measuring on that particular perfusion CT maps, those values, you wouldn't get the same one that she reported, again, because you are underestimating those values. Now, that being said, if you window appropriately this map, you are going to have appropriate relative values. So typically, if you want to compare what's happening on the right side with what's happening on the left side, it's going to work well, because you can, again, see what is relatively different from on the two hemispheres. And typically in a stroke, since one hemisphere is going to be affected, you are going to be able to detect and characterize the abnormality. One slight note, when the maximal slope model was originally proposed, the people who developed that particular model recommended very high injection rates, 10 to 20 cc per second, because again, they wanted to minimize the leakage of contrast to the capillary bed to reproduce as closely as possible the microsphere model. But as you can imagine, we're discussing here 10 to 20 cc per second injection rate in small peripheral IV lines in the arm of the patient, which is not the most comfortable injection technique. And since then, those proponents of the maximal slope model have kind of stepped back and recommend typically 4 to 5 cc per second injection rate, but with the important knowledge that your values are going to be underestimated. So typically, if you are using one of those software, remember that the absolute value that you are going to measure when you draw region of interest are not going to match the values that you would get with a different type of software that we're going to discuss in a minute. But relatively, if you compare the right and the left side, this is going to work. The second big group of analysis that you can perform is called the central volume principle. And this type of approach is considered to be much more quantitative in terms of the value that you observe. Typically, it's a more complex calculation. It involves a complex mathematical operation called deconvolution. I'm not going to go into the detail of deconvolution, but the only thing to remember is that, again, you get values that are more quantitatively accurate. And now if I put the exact same data set, so it's the same gold standard xenon CT image, and I put on the right the exact same data set but processed using a different software using this central volume principle, you can see that the values are now much more correct, much more accurate in an absolute way. So you could put region of interest and you would get those values that Dr. Strother mentioned earlier, and you can get those values even with relatively low injection rates of 4 to 5 cc per second. So again, if I put those different images next to each other, you can see again the gold standard on the left, the xenon CT, that's the truth, and you can see those different results in terms of perfusion CT. So again, here the key message is that you need to know which type of software you are using, because depending on the type of software you are using, you are going to get different results. There are, of course, efforts together with the different imaging manufacturers to try to overcome that limitation, because after all, it would be much simpler to have the same map produced by every single software. But I think in the meantime, until this goal is reached, as long as you know what type of software you are using, you'll know the advantages and the limitation of that particular software, and you can make a very good use of those perfusion CT maps. The third element that I wanted to address is that we have discussed about those different maps. And one thing that you need to know is that they are sometimes called differently by the different manufacturers. And when you think about it, finally, there's a lot of commonalities between perfusion CT and perfusion MR, and you just need to know how the different parameters are called and the different names that finally apply to the exact same concept. So typically when you do perfusion CT or perfusion MR, you get those time curves. There are time density curves for CT, and there are time intensity curves for MRs. And typically when you look at the different parameters that you can calculate, so if you use the maximal slope model, you are going to use either the maximal slope of increase on CT or the maximal slope of decrease on MR to calculate your cerebral blood flow. And again, those are different names that can be used by the manufacturers. If you look at the area under the curve for CT or the area over the curve for MR, that's going to be your cerebral blood volume. And again, those different names are used by the different manufacturers. And finally, if you try to characterize the time, you have different parameters that you can calculate. You can calculate the time to maximum, a time to minimum, and they also call time to peak, again, depending on the manufacturer, but they always designate the same concept. Finally, you have to remember also that you can measure kind of the width of your curves. They have different names: full width, half maximum, mean time to enhance, mean transit time. Be careful though, because the mean transit time term should be reserved to those software that use deconvolution, and the mean transit time is the result of this deconvolution. So in summary, two big group of perfusion CT technique: whole brain and dynamic. Dynamic can have limited coverage or be also the whole brain. Then you have different types of algorithm, different types of software, but two big groups, basically a maximal slope model and central volume principle, and different types of map that can have different names. So again, you just need to know what your software does and what types of map it produces and how they are called by your particular manufacturers. Now, how do you interpret the perfusion CT map? So typically you are going to rely on the time parameter, whatever it's the mean transit time, the time to peak, the cerebral blood flow, and the cerebral blood volume. I typically always look at mean transit time first, because whenever it's abnormal, that tells you that there is something. If the MTT is normal, then in 95% of the cases, the other maps are also going to be normal. So it's a good way to screen your patient. And then you just need to remember this pathophysiology that Dr. Strother described. Initially, the brain is going to respond by vasodilating vessel and recruiting collateral. So the CBV is going to go up. The CBF, that is nothing but the CBV divided by the MTT, is going to remain normal at first, typically in a TIA. But after that, when you really are dealing with a stroke, the CBF is going to go down. So that's typically the second map I'm looking at. When I see increased mean transit time, I'm checking whether the CBF is preserved or whether it went down, which will tell me I'm dealing with a stroke. And if I see that the MTT is up, the CBF is down, then I'm trying to look for subregion where the CBV is still preserved, not enough to compensate and maintain the CBF, but still up. That will be my ischemic penumbra. And I try to distinguish those subregions with those that have a decreased CBV that will correspond to the infarct core. And that's the way you can differentiate those different regions. And then you can use those thresholds that Dr. Strother mentioned, 145%, 2 cc per 100 gram, but that applies only to a specific type of software, namely those using deconvolution. It will not, those values, the concept will still work with all other softwares, but those values for those thresholds will be different. Now, to be fair, I still want to say that there are a number of methods that have been described to try to characterize the infarct core and the penumbra. Usually those different methods give very close results, but they have not been systematically compared. So again, probably that the software you are using is using a method to calculate the infarct core and the penumbra, and you just need to know which method is that, and just be aware of the limitation of that particular method that you are using. There are still some debate on how to use those results, and typically people want to extend the window for treatment of acute stroke, need to decide how they are going to use this information together with the clinical information to obtain the best outcome possible for the patient. Now, just a couple of points that I want to make before I finish. So in terms of how long does it take to get this imaging? So The non-contrasted CT in terms of acquisition is very short, especially with modern scanner, a couple of seconds. For the CT perfusion, it depends a little bit on how you obtain it and how many boluses you obtain, but typically it's going to be a couple of minutes, and then the CT is usually short. Then you have to factor in on top of this acquisition, typically 5 minutes, you have to factor in the processing. And the processing, again, applies for the CT perfusion and the CTA. CT perfusion is shorter and shorter. Now there are even ways to automatically process your perfusion CT data set so that it goes really fast. But overall, what you have to keep in mind is that in something like 10 minutes, you can probably get all the results from this advanced imaging. And that's something I believe we're going to discuss later in the forum. But in other words, it doesn't delay treatment to obtain those additional images. It just brings you additional information. In terms of safety, so you are going to get to administer to the patient some iodinated contrast. There have been large studies that have been obtained, and I'm sorry here, an article was supposed to show up and it doesn't. But in summary, what the article was saying is that it's safe to give contrast in those stroke patients, even if you have not been able to measure their creatinine in advance, especially if they don't have any history of renal failure and if they are not known for diabetes. And in a lot of centers, usually for those acute stroke patients where time is of essence, time is brain, we do not wait to get the result of the creatinine back. We give the contrast because it has been, again, proven in series of more than 1,000 patients that it's safe to proceed that way. The other concern, of course, in addition to the nephrotoxicity risk, is the radiation dose concern. And you have all seen those images of a patient who got an haircut by the perfusion CT study. So there are a couple of things that you need to keep in mind. The first thing is that you need to perform your perfusion CT studies using specific parameters. And those parameters are 80 kVp and 100 mA. The radiation dose increases with the square of the kV. So if you use 120 or 140 instead of 80, you are going to give a radiation dose to your patient that is going to be 4, 5, 6 times what it should be. The radiation dose increases linearly with the MAs. So typically you don't want to give 400 mA, you want to give 100 mA. You want to minimize the radiation dose. And the different perfusion CT software are able to correct. The images are going to be grainy, noisy, but the perfusion CT software can correct for this noise. So really what you want to keep in mind, and that's perhaps the most important message of my talk, is keep the kV at 80, keep the MA at 100, and that way the amount of radiation dose that you deliver to your patient is in the range of 2 millisievert, which is the same as a non-contrast head CT, and that way you won't see those patients with those haircuts and you won't end up in the newspaper. So that's a very important point. You want also to think about those other techniques. The shuttle technique, it has some limitation in terms of temporal resolution, but it allows you to increase coverage and to diminish radiation dose. And finally, you want also to remember that the perfusion CT is one thing, but the CT is going to give more contrast and more radiation dose. And an conventional angiogram is going to give even more radiation. So typically, it's not so much one study that is going to matter, but it's patients who are going to get several perfusion CT, several CTAs, several conventional angiograms. And typically, those, by the cumulative effect of the dose, are going to develop the complication. And perfusion CT will be one component. It will be the visible component with this typical hair pattern, but it will not reflect just the dose of the radiation dose of the perfusion CT. It will reflect the radiation dose received by all those imaging techniques. So have a plan in terms of which technique you are going to use. It applies for stroke. Dr. Strother showed the algorithm that she is using. I showed the algorithm that we are using. I have also a plan for vasospasm. Those patients are going to come back multiple times. Have a plan for which technique you are going to use so that you can minimize the cumulated radiation dose. So in summary, I wanted to really reiterate that perfusion CT is a safe technique if it's performed properly with the adequate parameters. It's really easy. You don't need a special equipment. You just need a software, and the manufacturers have done huge efforts to make those software really user-friendly. perfusion CT really gives a lot of additional clinical information at really limited cost in terms of time, of efforts, and really can improve patients' management and outcomes. So I'm sure that Megan will join with me to recommend that you use this technique because it's really a great technique and it can help our stroke patients.